Hello and welcome everyone. In this video, we are going to do a rapid fire review of the OBGYN trauma and dermatology CCS cases. By mastering these cases, you will be able to score more than 90% on the CCS cases for step 3. If you like this content, please like, share and subscribe and follow for more, and let's begin. OBGYN. So the two specific tests that you have to remember in a patient who is pregnant are doing fetal Doppler along with fetal heart rate, right? Because you have to not only check for maternal well-being but check for the fetal well-being. So don't forget to do the fetal Doppler and fetal heart rate. So let's begin with the first case, which is preeclampsia. So now the goals of diagnosis are to divide it into, again, the radiological tests, the blood tests, along with some sort of renal or urine test, since we know that preeclampsia also affects basically the urine or the renal system, right? So for the blood test, we are going to do a PTT or APTT, and also we can do LFTs in order to rule out HELLP syndrome, right? And similarly, since the patient is like at acute risk of bleeding along with undergoing some sort of surgery, so we are going to prepare for that by doing a blood type and cross match. So these are the coagulation tests or the liver function tests which we are going to do in the blood test. Next off, we have the radiological diagnosis or the radiological test. In that situation, one would be the mommy test and one would be the baby test. So the mommy test would be an ultrasound of the pelvis or a transvaginal ultrasound. And next off, for the baby, to look for fetal well-being, we are going to do a fetal Doppler, right? And since, of course, we know that preeclampsia involves the renal system, so we will do a 24-hour protein test as well as monitor the patient's urine output. And do not forget to admit the patient if she is serious, admit her to the ICU, or if she is stable, then admit her to the inpatient unit, because you cannot do this 24-hour protein along with monitor the urine output if the patient is actually like in the outpatient department, and moreover, like the patient is at risk of actually developing eclampsia and developing seizures and intrauterine fetal death. Therefore, we need to admit this patient, right? Okay, so for the treatment, one is the specific treatment for seizures, one is the specific treatment for the blood pressure, and one is for the baby, fetal lung maturation. So two for the mom and one for the baby. So the two specific things you're going to do for the mom is blood pressure management with either labetalol or hydralazine, and the prevention or the treatment of seizures by giving magnesium. And next off, for fetal lung maturation, if the baby is less than 34 weeks, we can administer dexamethasone. And we are going to do, of course, an OBGYN consult for the planning of C-section and delivery. Next off, we have pelvic inflammatory disease. Again, for pelvic inflammatory disease, we can do some sort of STI testing in order to confirm what is the infectious cause that is causing this pelvic inflammatory disease. And we can, besides that, we can also do some sort of urine vaginal tests or urethral tests, right? And next off, the third main step would be a radiological test. So first of all, the STI panel, and remember to do this STI panel in all of those patients who are involved in high risk behavior, those who are sex workers or men who have sex with men or any such unprotected risky sexual behavior. You should always remember to do this STI panel, which includes doing the chlamydia and the gonorrhea antigen, the HIV and the Hep B and C serologies, along with doing the VDRL test. So these are the 5 main tests in the STI panel: chlamydia, gonorrhea, HIV, Hep B and C, along with VDRL for syphilis. Next off, in the urine and the vaginal testing, you can do a urine culture and as well as the gram stain, a cervical wet mount specifically for trichomoniasis, along with bacterial vaginosis, Gardnerella vaginalis, and you can also do a gram stain of the cervix uteri as well as the vaginal discharge. And in the radiological test, you can do an ultrasound of the pelvis, and specifically if you find out that the patient is infected with gonorrhea or chlamydia, then you can administer ceftriaxone for gonorrhea treatment and doxycycline if the patient is not pregnant and has chlamydia infection, or if the patient is pregnant, she can be given azithromycin. And the prevention, of course, safe sex counseling along with sexual partner treatment advice. Next off, we have dysfunctional uterine bleeding. So in the diagnosis of dysfunctional uterine bleeding, again, we can divide it into the endocrine blood tests, right? Similarly, we are going to rule out some complications of the dysfunctional uterine bleed, and we are also going to do some radiological tests, and we are going to rule out some hematological cause that is causing the bleeding. So first of all, in the endocrine test, we have FSH, LS, LH, HCG, beta HCG, which you are going to do for any woman of reproductive age group, along with prolactin levels. So these are going to help us determine whether there is some endocrine abnormality that is causing the dysfunctional uterine bleed. So that would be FSH, LH, HCG, along with prolactin. Next off, if this dysfunctional uterine bleed is actually causing postural hypotension, for this you are going to do a postural blood pressure. Next off, for the radiological test to find out that if say there's something that's going on in the pelvis and there's some structural anomaly over there, then you're going to do an ultrasound of the pelvis, and for ruling out some sort of hematological cause, do a PTT test. And the treatment of dysfunctional uterine bleed is just oral contraceptive pills. Next off, you have spontaneous abortion. Again, for spontaneous abortion, you can divide it into radiological tests to confirm the diagnosis and some blood tests to prevent the complication that can occur with spontaneous abortion. So the radiological test would be an ultrasound of the abdomen and pelvis, and the blood test would be doing the type and the cross match, so that the blood is ready for you in case the patient is bleeding excessively and might be at risk of hypovolemic shock. Next off, we have the treatment. So in the treatment, we are going to divide it into surgical management along with medical management, right? And in the medical management as well, there would be the supportive management and the definitive management, which will assist with the abortion, right? So let's first of all begin with the supportive management, supportive medical management, right? So it's possible that the patient can develop a septic abortion. Therefore, you are going to give prophylactic antibiotics in order to prevent infection, and that would be either metronidazole or doxycycline. Next off, in the symptomatic management, you can give to reduce the post-procedure bleeding, you can give methyl ergonovine, right? Or oxytocin as well. The first mainstay is oxytocin, and after this you can also give methyl ergonovine, right? And in the definitive medical management, you can give misoprostol, which will help with the ripening of the uterus as well as assist in the abortion. And if the patient is infected or hemodynamically unstable, then you will not do medical management, since again it can become a septic abortion, patient can develop septicemia and die. So we'll directly go to the surgery and do dilation and curettage, right? And of course, you're going to consult OB/GYN. So next off, we have sexual assault, right? In sexual assault, with the first goal of diagnosis is to establish some sort of evidence, right? And that is, you can say that confirm the diagnosis, right? So first of all, you will do a rapid evidence kit. And next off, you are going to consult social services, because again, you have to do something on your part, provide the evidence on your part, and transfer this information to the relevant department, which is social services. In the treatment, of course, the patient is at risk of STIs, right? So first goal would be to prevent infection. Next off, since the patient has been assaulted and if she is a female, she is at risk of a pregnancy, right? So we are going to prevent pregnancy. And next off, specifically in the infections, she is at risk of the viral infection, which is HIV. Therefore, you can give antiretrovirals. And of course, the patient has some sort of psychological impact from the assault as well. Therefore, prevent some sort of psychological adverse outcome as well by consulting psychiatry. So first thing first, in the prevention of infections, in order to prevent gonorrhea, you are going to give ceftriaxone. In order to prevent chlamydia infection, you will give doxycycline or azithromycin. And for the prevention of bacterial vaginosis or trichomoniasis, you can give metronidazole. So these are the three main drugs: ceftriaxone, doxycycline, and metronidazole. Next off, we can prevent pregnancy by giving emergency contraception, which is levonorgestrel, and you can also give ulipristal. And for the prevention of HIV, you can give prophylactic antivirals, which are tenofovir or raltegravir. And for the prevention of psychological adverse effects and depression or stress caused due to this particular event, you can consult psychiatry. And in the prevention, you can do, in the further follow-up, you can do VDRL at 4 weeks and 3 months, just to ensure that the patient did not get syphilis from this assault, right? And similarly for HIV testing, you can do it at 4 weeks and 3 months. So 4 weeks, you can remember it as 1 and 3 months, right? At 1 and 3 months, do VDRL as well as HIV testing, and advise the patient not to have any further intercourse during this time, till the time that we are actually confirmed that the patient does not have any of these infections. Next off, we have ectopic pregnancy. So if the patient presents specifically with ruptured ectopic, that is an emergency situation, right? If the patient does not have a ruptured ectopic, of course you are going to still admit and monitor the patient because the patient is at risk of getting a rupture. But if the patient has a ruptured ectopic, you will quickly confirm the diagnosis with an ultrasound of the pelvis, and then after confirming the diagnosis, you're going to avoid CT scan and X-ray of the abdomen. Like, there's no need, just confirm the diagnosis with ultrasound of the pelvis and directly move to surgical management, right? So first of all would be the general supportive management, since the patient might be bleeding internally. So to support her till the time you can get a blood type cross match and transfuse, you can do a fluid replacement, along with, if the patient is vomiting actively or has nausea, give ondansetron, and for the pain control, give morphine, right? So the general supportive measurements would be for circulation, that is fluids, for vomiting, which is ondansetron, and for pain, that is morphine. And then of course you're going to surgical management, do all the nice PT surgical orders of NPO, informed consent, cefazolin, along with EKG, PT, APTT, as well as blood type and cross match, and then consult OB/GYN for emergency surgery. But if the patient still does not have any evidence for ruptured ectopic, then you can go for the medical management, specifically with methotrexate, and along with methotrexate you are going to monitor the serum beta HCG levels, whether they are going down or not. Next off, we have menopause. So for menopause, again, we are going to confirm the diagnosis with some specific test. We are going to rule out some other causes that can mimic menopause, which include some endocrine causes as well as infections. And we are going to do some radiological test in order to rule out some sort of breast mass before we actually give the patient oral OCP, since the patient, of course, might be some lady who is 45, 50 plus years of age, and she is at risk of developing breast cancer. So always do a mammogram before actually giving the patient some sort of estrogen or oral contraceptive pills, since oral contraceptive pills might actually worsen her breast cancer. Okay, so to confirm the diagnosis, the most sensitive and the specific test is FSH, which is going to be increased. Next off, to rule out the other causes such as hyperprolactinemia or thyroid problems, we are going to do a prolactin as well as TSH test, and in order to rule out infections, we will do a cervical wet mount. And next off, the radiological test would be mammogram to rule out some sort of breast mass before we give the patient OCPs. And the treatment, the symptomatic treatment, can be simply giving vaginal estrogen and vaginal lubricating agent. And if the patient has hot flashes and is symptomatic, then we can give citalopram or we can give estrogen replacement therapy. And of course, like, the only indication for giving estrogen replacement therapy is when the patient is having symptomatic distress and the vasomotor distress because of menopause. Then only you can give this SSRI such as citalopram as well as estrogen replacement therapy. Otherwise, it's just the general supportive management with vaginal estrogen and vaginal lubricating agent. Next off, we have trauma. So in the trauma, the first case is that of drowning, where the patient will come to you with a history of course, drowning with a weak pulse, bradycardia, and hypothermia, right? So you are going to do the basic and the emergency order. So always remember the basic orders with C5, UP, and then G3, M1, Maple, remember, M1, P2, and L3. So if you want a quick review of these orders, you can go to the first video in the series which says Rapid Fire Review, General and CVS, and there I have explained these orders in detail, but just a quick review. C for CBC, CRP, CMP, CPK, and CXR, which is chest X-ray, along with urine analysis, culture sensitivity, toxicology, screen, beta HCG if she might be pregnant and is a woman of reproductive age group, hemoglobin A1C, ESR, EKG, echo, TSH, troponin, toxicology, then magnesium, phosphate, PTA, PTT, lipid, lactate, and LDH. So these are the basic orders, and of course the emergency orders basically include doing a pulse oximetry, cardiac monitor, blood pressure monitored, IV access, along with starting the IV fluids. If the patient is having respiratory difficulty, then intubating as well as ventilating the patient and giving supportive oxygen if the saturation is low, along with doing the ABGs, right? So these are all the basic and the emergency tests which you can do a revision by watching the video number 1 again, right? So now we have the specific treatment. Now the goals for specific treatment are dependent upon the signs and symptoms, right? So this patient is having 3 difficulties. He needs some sort of severe support because she or he has weak pulse and bradycardia, needs some sort of temperature support since she or he has hypothermia, and needs some sort of respiratory support because the patient might have fluid in the lungs that might cause ARDS, right? So for the emergency resuscitation, you are going to do a CPR if needed, and intubate and mechanically ventilate and IV access and start IV fluids, right, to control the hypotension, right? Okay, next off we have, this was for the resuscitation and the respiratory support, right? Next off we have the temperature support. Since the patient is hypothermic, we're going to remove the clothing and put on a warming blanket onto the patient. So because the clothing might be drenched with water and might make the patient more hypothermic, so remove the clothing and put on a warming blanket. Next off we have the severe support with fluids and epinephrine. Fluids is the first mainstay, but if the hypotension is not improving despite the fluids, we are going to start on epinephrine, and of course still if it doesn't improve, then if the patient is also like bleeding actively from somewhere, then we can do blood type and cross match along with transfusion. Next off, we have non-accidental trauma, specifically in cases of child abuse, where the baby or child might present to you with some sort of spinal fracture or burns or like some other injury like that, right? Then for the diagnosis, you are going to do a radiological confirmation that the patient does not have other injuries beside this. So of course, if the patient has some spinal fracture of the femur or the humerus, you are definitely going to do an X-ray of that particular area. But besides that, you will do a complete skeletal survey to assess for other broken bones, and you can do a CT of the head as well to rule out some sort of subarachnoid hemorrhage or head injury, specifically in case of babies who might have shaken baby syndrome, right? So skeletal survey along with CT of the head. Next off, there are like 2 specific managements that you can do. One is again the supportive management, and one is the definitive management of the wounds if the patient has burns. So the supportive management, since you know that a patient with burns is going to lose the fluid very rapidly, so you can give ringal lactate, and in the surgical management you will remove the dead skin caused by the burns by surgical debridement, right? And of course, if the patient has burns, then plastic surgery consult. If the patient has broken bones, then orthopedic surgery consult. And of course, you are going to admit the patient in the inpatient unit and consult social services and call child protection service. Next off, we have dermatology, and in dermatology, the first case is Steven-Johnson syndrome that is usually caused by some sort of drug reaction that is going to cause a widespreading vesicles formation and skin denuding, right? So what you are going to do specifically over here is that you are going to look for this specific cause, establish the diagnosis, a histopathological diagnosis by a biopsy of the skin. Number 2, you are going to do some radiological tests to find some associated complications such as pneumonia. The people who have SJS have high risk of pneumonia, therefore you're going to do a chest x-ray. Next off, the third, you're going to rule out other associated complications by doing blood tests, right? The first complication you found out by doing a radiological test of chest x-ray by ruling out the pneumonia. You did a histopathological test to confirm the diagnosis of SJS by a skin biopsy, and then you are looking for additional associated complications in the blood, such as you can do a serology for mycoplasma, because mycoplasma is also associated with SJS in children, and you can do a bacterial culture of the wound to rule out some sort of infection. Now, in the treatment, the mainstay of treatment, of course, you're going to stop the causative agent, right? And besides this, the supportive management will be with fluids, again, since you know that the patient who has burns is at risk of rapid fluid loss because of the denuded skin. So give rapid fluids along with, since the patient has wounds, so we will do wound management. And next off, to slow the progression of SJS, there is a specific medical management which is cyclosporine. Next off, we have cellulitis in a patient who has uncontrolled diabetes. So of course, for the area that has cellulitis, you can do, if that area has active pus coming out, you can do a wound culture sensitivity, wound, gum stain, wound culture sensitivity, pus culture sensitivity. But if there is no active wound and it's just like plain simple cellulitis that is not weeping or bleeding pus or oozing pus, then you can simply do three things, right? One thing would be a radiological test to rule out DVT if there is some underlying DVT under the cellulitis, that you can do with doing a Doppler of the lower extremity in order to confirm the diagnosis and to confirm whether the patient has systemic infection. You can do blood cultures, and for seeing the extent of the diabetes, and diabetes is an associated risk factor for the development of cellulitis, so you can do HbA1c as well. So three mainstays: rule out DVT with lower limb Doppler, confirm the diagnosis if the patient is having septicemia as well as like the blood infection by doing blood culture, and the associated risk factor of diabetes assessment by doing HbA1c. Next off, we have the treatment. So of course the patient might be hypovolemic, so you can do fluid replacement. That is the general, or you can say the symptomatic management. And for the pain and the fever relief, you can give acetaminophen. So these are the supportive or the symptomatic management. Then for treating the cause, you can specifically give ceftriaxone or vancomycin. And for the treatment of the associated risk factor, which is diabetes, since you want the diabetes to be controlled right now, you're going to admit the patient and start him on insulin. And once the patient improves, then he can be shifted onto the oral antidiabetics, but for now he should be given insulin to rapidly control the diabetes, because the cellulitis will not be cured until and unless his blood glucose levels are normalized. And of course, in the prevention, you will give all the instructions for diabetes by maintaining a low carbohydrate diet along with low caloric diet, exercising, wound care, right? All these things that you do for diabetes, along with, if you want to, you're going to do microalbumin levels, ophthalmology consult, nephrology consult to look for the complications of diabetic nephropathy as well as diabetic ophthalmological complications, diabetic retinopathy. And that concludes our rapid fire review of OBGYN, trauma, as well as dermatology CCS cases. I hope that you found this video beneficial. If you like this content, please like, share and subscribe and follow for more. And I'll see you in the next video. Happy studying!